It's a delight to be here today at the 49th VEIThsymposium in person. And we're discussing the latest trends in carotid artery disease. And we're really fortunate to have with us two of the experts in the field, Dr. Michel Makaroun and Dr. Chris Metzger. And let's just start out with Dr. Metzger. People here at the meeting want to know the latest, but there's a lot that's latest. So I'll ask you, what's the most important latest development in carotid disease in your view?
So we're going to start out easy, huh? There's a lot of good things happening in the field of carotid intervention, as you know very well. First of all, there's your ongoing CREST-2 trial that's going to say, hey, is revascularization better than medical therapy or is equivalent? But then in terms of what we can do for revascularization, there's all the excitement around TCAR. Maybe too much excitement, but it's certainly a great technology. And then in the field of transfemoral and transradial carotid stenting, there are trials going on right now, Performance 2, which just finished, which incorporates a second filter basket in a 3-in-1 delivery system. And the other one that I'm the primary investigator on, the C Guardians, that has a micro mesh, very novel carotid stent. So those two devices should reduce further the minor strokes seen with carotid artery stenting, and the micromesh has a potential to lower the peri-procedural strokes when we're done with a carotid stent because of the extra micronet layer. So I think the idea of us all thinking together, new technologies, thinking where is medical therapy best, where is TCAR best, where is endarterectomy best, and where is transfemoral stenting best. It's exciting times.
I did Google today, and I just put in TCAR. I got 1.8 million hits in 0.42 seconds. And Michel, I'll ask you, what's your view in terms of the place of TCAR relative to surgery?
Well, clearly it's a new method in the toolbox that can be used for the right indications to hopefully improve the outcomes of what we are trying to achieve, which is reduce the stroke rate in the future. I think it has already established itself as being rather safe procedure that can improve in high-risk situations the outcomes that you can get from revascularization of the carotid artery. I guess you know that the FDA has authorized its use in low-risk or normal-risk patients recently. Although the final result or place for TCAR in the armamentarium of carotid artery treatment remains to be determined in the future, depending on the implementation across the whole United States in the hands of people who are not currently using it and very experienced with it. But clearly, it is a big improvement in the abilities to handle some patients with significant comorbidities or anatomic high-risk criteria for the treatment of carotid disease by bypassing the arch, as you know, and reducing the chance of embolization from the arch.
Go right ahead, Dr. Metzger.
So a follow-up question to you, Mike, as a surgeon. Is there any concern on your part that there's so much excitement and so many people enamored with TCAR that sometimes the surgeons seem to be doing everything they can to do TCAR when, for example, shockwave in a carotid stent with TCAR, as opposed to good endarterectomy in a calcified lesion? Is there too much movement towards TCAR, or am I wrong?
I am not going to dispute this. Actually, it should probably come to the debate we're having on Friday. The hype, it's something that actually tends to come with every single new procedure that is introduced. And both you and I remember the early days of transfemoral carotid artery stenting, and there was plenty of hype around then too. So I do agree with you that there's maybe too much attention being given to this new procedure. I personally have decided that I am on the tail end of my career, and it's always important to get a lot of experience in the procedure to get the best results. So I refer the patients that I believe could benefit from this to the few partners that we have designated as those who will be performing TCARs in our group. But I have found that certain patients probably could benefit from that procedure. But I would say that the majority of my patients are still getting carotid endarterectomies.
Another big development has been the publication of a new randomized trial with asymptomatic patients in a medical group. So we had 513 patients in the SPACE 2 trial. 100 of them, a little over 100, were treated with medicine alone, and those patients did very well. Now, the numbers show that the surgical morbidity of 2.3% from ACAS way back in 1995 is about the same in trials today as it was then. But of course, statins have changed the atmosphere. People aren't smoking as much. Blood pressure is changing. And I ate lunch today with a vascular surgeon from Denmark where they don't do asymptomatics at all. So I guess I'll hand it over to Dr. Metzger and get his view on SPACE 2 and the asymptomatic patient.
Great question. I think like everything we do, this is an individualized decision. Okay, now, if you're asymptomatic and you're elderly and you have high risk features for revascularization, for sure, medical therapy is going to be your best ticket. If you're a young, healthy 60-year-old with a 90% carotid, I would submit that if your procedural risk is proven and documented to be very low, and we know from 10-year CREST data that once you get through the procedure safely, 10-year outcomes are outstanding for the therapy. I believe that we should get to a point where we can have a individualized discussion with the patient. Sir, ma'am, here's a risk that we know from medical therapy, and here's a risk for revascularization. And then have that discussion and let them participate in it. I hope we get to that point where we can do that. I think that every patient that we treat, whether it's Mike with endarterectomy, whether it's me with transfemoral stenting, should be treated with optimal medical therapy. And then the question is, do you add to that revascularization? Finally, I would also throw out there, we still do not know how to predict who's going to have a stroke and who's not. And if you're 60 years of age, you now have hopefully 20, 25 years left of cumulative yearly rate of stroke without revascularization. I'm not sure we know the answer to that one. I would say if I could do your stent for less than 2% risk of any stroke, and then the results are durable, I would have that discussion with the patient and let them help decide it.
So the individual patient. Dr. Makaroun, when you see a patient, what are the individual features of the patient that push you in one direction or another, whether it's timing in the symptomatic patient, or it's whether or not to do endarterectomy in the asymptomatic patient, those two patients?
Maybe I will add a little bit to what Chris said regarding the asymptomatic disease. I tend to agree with him that not all asymptomatic lesions should be lumped together as one category. I don't think anybody disagrees anymore that medical therapy has changed the natural course of the disease, and that many patients are much better left off with medical therapy alone. And certainly nobody promotes the ACAS limit of 60% cutoff for the treatment of asymptomatic disease. Now, when I'm in the office and I'm essentially seeing a patient, usually in the office most of them are asymptomatic, frankly. I tell anybody who's essentially over the age of 80 that I probably will see them only when they become symptomatic, and they are welcome to come back and I'll be happy to take care of them. That there's no point in operating on them or providing them with a stent, whether it's TCAR or transfemoral. Younger patients with severe disease who especially have some additional comorbidities or at least characteristics of the plaque on duplex ultrasound or a variety of other imaging that suggests that they are at a higher risk of developing a stroke, I'm still offering them some form of intervention, usually carotid endarterectomy, especially for the younger patients who have a very severe stenosis. But there's no question that nationwide and in our own offices as individual practitioners, the number of patients undergoing interventions in 2023 or 22 are far less than 10 years or 15 years ago. I think nationwide the number of patients getting interventions are probably half of what they used to be in the past, although the hype around TCAR may be changing that a little bit.
We're supposed to talk about what's new. This meeting has some new things in medicine. One has been the use of thrombin inhibitors in combination with one or even two antiplatelet agents. What's your view of this new information regarding thrombin inhibitors in carotid disease?
Great question. I think we have to be practical and then, again, individualize that again. I live in Tennessee where people are wonderful people. They don't always have the greatest financial resources. So part of it is what's their bleeding risk, number one, what's their stroke risk, and what's their wallet biopsy look like? In other words, if I'm trying to get them to take a high dose statin, quit smoking, and they need dual antiplatelet therapy, if the insurance is not going to pay for the revascularization, for example, and their bleeding risk is a little higher, then I'm not going to press real hard for that. If they need dual antiplatelet therapy because they just received a drug-eluting coronary stent, again, a little less likely to push it. On the other hand, if they have other risk factors for DVT and so on, you may go. So I think it's individualized, bleeding risk, insurance, comorbidities, what other medicines they need to take, those kind of things. It is something that we can offer people that say we may be able to reduce your risk further in the right circumstances.
How do you evaluate these new stents? Open cell, closed cell, covered stent. When morbidity is so low, your event rate's so low, how do you know whether or not a new stent, we have several at this meeting, how do you evaluate them?
First of all, I think what we need to not do is what too many companies have done lately and done this per protocol analysis. Okay, in other words, it has to be intention to treat. You can't, the company sponsor cannot exclude people and then tell you about it per protocol. That's number one, okay? Number two, you're right, we couldn't do a trial powered to tell the small differences between events, but I think you can do accurate adjudication with neurologic independent adjudication and regular duplex, and then you can make some pretty good comparisons. I think that some of the technologies should reduce peri-procedural strokes, both during the stroke and then the 24 to 48 hours afterwards, and we should be able to see that in a trial. As you know very well, CREST-2 has allowed some of the newer ones in so that it could be a contemporary trial, which is much to the credit of the trial. So I think we just have to look, but I think we have to look honestly with intention to treat analysis and careful adjudication, and I think we will be able to get some answers.
We've been talking about medicine, stents, technology, but I've noticed that carotid surgery, when I first looked at it in 1980, has become more and more safe with regard to endpoints. In the CREST trial, symptomatic patients operated upon by vascular surgeons had a stroke and death rate at 30 days of around 2%, which is remarkably low. What's happened in surgery? What's come up at this meeting to explain why surgery's become safer?
I totally agree with you. Carotid endarterectomy has become safer, and probably most of the credit goes to the medical therapy that now is employed in all the patients before and after. It is now more or less standard for us to start patients on statins before we operate on them. Many of us also start dual antiplatelet therapy for carotid endarterectomy. The number of practitioners around the country who are not fully trained in vascular procedure are essentially gradually phasing out their practices. So the bulk of carotid endarterectomies in the general population is being done now by essentially fully board certified full-time vascular surgeons. In addition, I think the VQI has come up with a fair number of indicators that suggest that certain things will improve the outcomes of the procedure. And they are actually being implemented nationwide as being part of the VQI. On top of that, I think there are a lot of other refinements that unfortunately are much harder to disseminate, and I will talk about one of them in my debate on Friday, because we do not have the financial resources to disseminate newer techniques that can actually also improve those outcomes further. But your observations are all correct. The amalgamation of all the knowledge that has been accumulating for the last couple of decades has really rendered the procedure itself much safer.
And finally, Where do you see carotid surgery in 10 years?
I believe that carotid endarterectomy remains by far the best method of treating carotid stenosis if the patient is a candidate for that procedure. I still do transfemoral carotid stenting myself, and I used to actually do a lot before the crest. After the crest kind of slowed down a little bit. I believe that TCAR is probably going to take a portion of that away. But I have been around the practice of vascular surgery for almost 40 years, and I have seen the knocks on the door that it's going to go away, it's going to disappear, come and go, and carotid endarterectomy remains standing as the best thing we can offer to the patients who can actually tolerate it and are good candidates for the procedure. And I still believe that 10 years from now still will be the case.
Where will endovascular techniques for treatment of carotid disease be in 10 years?
I will be, Lord willing, practicing for 10 years, so I think it's still going to be around. I think it's really going to be dependent on, first of all, there's much more of a trend towards the vascular surgeon doing more than the interventional cardiology, for example, community. A lot of them have left and gone down to the structural heart. So it kind of depends on the fairness of everybody evaluating what is the best procedure and the insurance and the CMS coverage of this. As you know, hopefully that will change. It's up for a national coverage decision. And I think the evidence is overwhelming that it should be on the table 10 years from now. I think if it's on the table for 10 years, I believe it should be, and I believe it will be, just like Mike would agree that endarterectomy will for sure be around. And I really hope that all of us get to the point where we don't think, hey, what does Chris do? What does Mike do? What does Tom do? But what is best for each patient? And I think if we do that, there is going to be plenty of room for each technology, and there's some advantages and disadvantages to each. And as long as we are all honest about that and refer, just like you said, if you don't do TCAR, but you have a TCAR expert, the best thing to do is pick up the phone and call them. I'm the first guy to call a surgeon and say this one's better for surgery than it is for stenting, or this one needs medical therapy alone. So I think it'll be around.
Thank you very much, and thanks to the VEITH meeting and all of the sponsors of the VEITH meeting for this 49th session.